Assalamu alaikum everyone. Thank you so much for coming here, and it's my great pleasure to introduce Dr. Raman Kumar to all of you. Dr. Raman Kumar is a consultant pediatric neurologist and assistant professor, currently heading the development pediatric unit at Liaquat National Hospital, Karachi. And he holds FCPS Pediatrics and a fellowship in pediatric neurology from Khan University Hospital. He also serves as visiting faculty at Center of Autism and Rehabilitation's Training and South City Hospital, Karachi, and a visiting consultant pediatric neurologist at the Balochistan Institute of Child Health. Dr. Raman is known for his expertise in neurodevelopment, seizures, stroke, and perioperative neurological care in children.
Thank you so much. Thank you for the introduction. It's really overwhelming for me sitting here and talking to my seniors. So, Dr. Fatma, I shared my fellow room with her at AQH. Dr. Babar was the section head, and Dr. Tariq, he was a fellow PICU. I was a resident, and so it's really wonderful feeling to be here and presenting. So, without wasting any time, so the topic that I chose for this for the presentation is stroke matters in children with congenital heart diseases. So we don't have basically set standard guidelines or protocols for managing these children with stroke, and so the risk stratification is very important. If we don't have the management protocols, then it's really very important to prevent or to have some kind of a risk stratification and base our decisions on those risk stratification strategies that we adopt. So we need to know the patterns as well in different congenital heart diseases. So my presentation is basically based on the fact. Yeah, sorry, that's very. So we'll be talking about the burden in congenital heart disease, the burden of stroke, and then we'll move on to a bit of pathophysiological mechanisms of stroke that is very important to understand. I know this is bread and butter for you, but still needs to be reviewed. Clinical and lesion specific risk factors. So that's a very important part that we need to know. And then acute neuroimaging modalities and protocols. This is very important, not just for the cardiologists and you taking care of the sick children, but also the neurologists. They need to be very well versed with the acute neuroimaging modalities and what images to see and which sequences to see. So we'll talk about it. And then radiological phenotypes of ischemic stroke and congenital heart disease, pattern recognition. So again, this becomes very important because MRI tells you a lot. It's like it tells you about the mechanisms going on, and the injury in the brain tells you about what is going on in the heart. So that is also the pattern recognition is very important. And then we'll move on to the value of standardized imaging scores. Do we have any score? If you send me a child and ask me whether he is fit for surgery or not, what is the prognostication of this child? So how do I answer that? So there has to be some standardization. So that's the basic. So that's the presentation layout. We'll start with the numbers, with the statistics as usual. So the study, this was an epidemiological study done in South Africa, China, and multi-centers, and it, according to them, as you know, it's the most prevalent congenital heart disease, is the most prevalent congenital disorder, and it affects approximately 1% of live births globally. So Asia has the highest prevalence, 9.3 per thousand live births, and then North America and Europe. So in 1950s, 15% children with congenital heart disease survived to adulthood, and now the number has grown over 90. It's like 97%. Some literature quote 97% they survive into adulthood. So if the navigation of the patient through this continuum from the neonatal age into the childhood, into the adolescent, and then into the adult, so it exposes that individual to to the risk of stroke. So so this is encouraging that the survival has increased, but with that the risk for the stroke has also increased, and we need to know it better. We need to have a command over this, so that so this is one thing that we need to take care of. So, and if we see the strokes in pediatric strokes, so 30% of all pediatric arterial ischemic strokes are due to the cardiac disorders. So this is one protocol in pediatrics. If we see a child with stroke, we need to get the screening echo done. So that is why this is a big number. So the this data, the study that they did, it says that congenital heart disease patients can be 10 to 100 times higher than at risk for stroke in than the age matched controls. And then they say okay, all those who have adult congenital heart disease, 1 in 11 men and 1 in 15 women are at risk for having, they have the, between ages of 18 to 64, they have a significant, this is the impact of this can be significant. So talking about, this is a meta-analysis, systemic review, meta-analysis done in 2024. And this is a Jordanian group, some researchers and cardiologists from, and the neurologists from Jordan did this study. And so they identified, there were 11 studies that were identified. And if we see the hazard ratio, so hazard ratio is a little different from the relative risk. Relative risk is the odd of having something, but the hazard ratio is when we talk about a particular event, the chances of that particular event in a lifetime. So stroke is kind of an event. So that is why this is measured in hazard ratio. So if we see, so very there are few studies with very predicting 10.76 of this ratio, and the minimum is around somewhere around 1.15. So the average of all the studies, the hazard ratio is 3.25 of having a stroke, all those with congenital heart diseases. And if we break this into stroke, as we know, the stroke can be hemorrhagic and it can be ischemic. So if we break that, so there were around 4 studies that were looking at the ischemic stroke, rest were looking at the hemorrhagic stroke. So in both the cases, the hazard ratio was came out to be higher. This was 4.45. So it is almost statistically same. We can't say that hemorrhagic strokes are less, or so, or ischemic strokes are, so they are the same. So this was the study in which 11 these papers were assessed. And so it said that according to age, the pooled risk of stroke, the hazard ratio in adult only was 3.27, and adult and children throughout, if they, when they analyzed, so it was again very high. And when they saw it through the regions, so Europe was 4.81, Asia was 1.90, maybe a very underreported. So out of these 11 studies that they picked, there were just 2 studies that were from the Asia, and rest were from the America and Europe. So, and again we see with ischemic stroke and with the hemorrhagic stroke, the hazard ratio was almost the same. It's 4.45. So this was concluded that overall the risk is very, very high in congenital heart diseases. So talking about pathophysiological mechanisms of stroke in congenital, just a revision: paradoxical embolism. Um, if there is a PFO or ASD, so a venous any thrombus from the venous circulation bypassing and then going into the brain. So it may lead to ischemic occlusion, large vessel occlusions, right? Usually these are large vessel occlusions. So arrhythmias are very, very common, and thromboembolism, because of the hemodynamic instability and the stasis and the clots. So arrhythmia is very, very, it can lead to atrial fibrillation, can lead to ischemic strokes. Then hyperviscosity, as we see because of the hypoxia and in cyanotic congenital heart diseases, secondary erythrocytosis, and then when the cells, there's a lot of turnover. The newer cells uh, they are very, red blood cells are very stiff because of the iron deficiency. So the demand is very, very high for the iron because of the turnover. So these are the stiff cells, and it may cause the stasis, the thromboembolism in the. And then septic embolism is also very, very common in as an infective endocarditis. So the vegetations on the heart tissues, damaged heart tissues or prosthetic material may move into that. And then hemodynamic failure can cause the hypoperfusion in the brain, and that may lead to stroke. So all the pathophysiology, the mechanisms, they have certain characteristics on the imaging. So what we need to do is we need to figure out whenever we see any uh, MRI or any neuroimaging, we need to just figure out the pathophysiological mechanism related to what could be the cause of stroke to the imaging and figuring out the mechanism, and then it becomes easier to for the risk stratification and further planning of our patients. So this was from this is a group from McGill, and they saw the clinical risk factors. And if we see atrial fibrillation uh, was very, very statistically significant in both univariate and multivariable analysis, and also the hypertension and congestive heart failure. So these were the very important risk factors in children with in person with congenital heart diseases. And if we talk about the lesion specific risk assessment, so cyanotic lesions, the prevalence reaching up to 23. This is basically from Sweden. This is a group that they figured out what is the prevalence and the risk factors of lesion specific risk factors for stroke. So cyanotic is very, very high. It's 23%. And again, the hazard ratio for the shunt lesions, ASDs, or paradoxical embolism was again very, very high. It was 3. And aortic valve lesions, they also carry a very, very high risk for 4.8 to 4.7 respectively. And other complex lesions, double inlet ventricles and aortic coarctation, there was no consensus on the numbers, but they said it is statistically significant. So this is very, very important. So when we talk about stroke, you send a patient to me with stroke. So don't take me wrong, but I'll use the strokes are not virgin. So they basically, when you send me a child with stroke, they already have a pre-existing brain lesion. So they are silent white matter changes, brain lesions, atrophies that actually affects the outcome of the child. So it is as high as half of almost half of the patient with congenital heart diseases, they have pre-existing brain injury, and 41% of in one study. This is from Boston Children, from the neurological, the neurodevelopmental department. The leads of the department did this study, and 41 they found 41% they have pre-procedural MRI. They found these injuries. So this is very very important. So we sometimes think that it's just the stroke or the lesion, that the acute lesion that and we need to make our prognosis based on that. So if we see a stroke in a child who does not have any congenital heart disease and a child who has congenital heart disease, the outcome, the neurodevelopmental outcome is not proportionate in congenital heart disease. So if we see a small lesion, the neurodevelopmental outcome may be not that good as compared to normal children, because they do not have a underlying uh, pre-existing brain injury. So, what causes this injury? Obviously, atypical brain development influenced by abnormal cerebral hemodynamics in utero, and white matter changes, lower brain volumes. So, this is very very important. When we do the risk stratification, we try to look at these numbers as well. So, so it is very important. Pre-procedural neuroimaging, it's fundamental in understanding the risk assessment, identifying infants who need enhanced neuroprotection during the surgeries or post-operative, and then the adjustment, specific timings and adjustments for cardiac interventions as well. So most of the times we keep on telling that this is the right time to do it, but obviously cardiologists saying that no, this is not the right time. So we need to have a kind of a agreement on, and that should be standardized. The agreement should be standardized based on some kind of scoring system, or there has to be a standardization. But this is really very important in order to make good decisions, when to do it, when to do the surgery, and when we once we are done with the surgery, post operative management, our intensities. So all depends on pre-procedural neuroimaging findings. It is not just the stroke, that if the child has stroke, we'll do the neuroimaging. So all the children undergoing should have a neurodevelopmental outcome kind of a assessment before going into the surgeries. So, talking about neuroimaging modalities and protocols establishing the standard of care. So, why we need early neuroimaging in stroke? So, it's rapidly diagnosing. So, rapid diagnosis is the key, because um, there are very few centers in the world that have the stroke, established stroke centers. So, in which time is really very important. Any intervention, acute intervention that you do, thrombectomy, mechanical thrombectomies, and thrombolysis, you need to have a very very rapid diagnosis. And then we need to differentiate between ischemia and hemorrhage, and then also we need to distinguish strokes from the mimics as well. So there are stroke mimics as well, and we need to be very very careful. Like one of them that we encounter is press. Press can exactly look like stroke on MRI finding, but we need to differentiate them. That's a reversible condition, and it may be reversed through uh, our hemodynamic changes that we make. So we usually CT or CTA is something that we choose because MRI is not available. But the first modality that we should always be using is MRI. And CT is quick, um, and we do it just to differentiate whether it's a hemorrhagic or ischemic stroke. So And also, if that's a hemorrhagic stroke, CT angio also gives you a bit of a little bit about the um, fistulas and the AV malformations and the structure of the vessels inside the brain. But they are very less sensitive for acute ischemic strokes. So MRI is really very important. So I see a lot of MRIs being done, and due to financial, uh, maybe resource limited settings and financial issues, we always order screening MRIs. So screening MRI consists of only one sequence, which is called T2 weighted image. So T2 weighted image is just a, even T2 weighted image does not pick the stroke uh, 24 to 48 hours after the stroke. So the earliest imaging modality that we have to order is DWI, diffusion weighted image. Now diffusion weighted image is really very important because the first pathology that occurs in stroke is diffusion restriction. So the diffusion gets affected within the cells in the brain, and a lot of water is retained. So if there is no diffusion, water stays inside. And what is MRI? MRI just it plays with the protons, and it's H2O, water, right? And hydrogen is in the form of H plus, that is proton. So what it does is a 1.5 Tesla magnet or a 3 Tesla magnet. If we put an individual in that magnet, it aligns all the protons in one direction. And when we keep on, we can't change the strength of the magnet. So that's a huge big magnet. So what we can change is the electrical field that we do. And by changing the electrical fields, we get different sequences. So T2, DWI, SWI, T2 star that we do. So all these are changing the electrical fields, keeping the magnetic field constant and getting different images. So when there is stroke or any injury in the brain, so the first thing that happens is there's restriction of water or fluid inside the cells. The diffusion gets restricted. The protons are they there are a lot of protons to be aligned, so we get a brighter picture on DWI even before the T2 picks it up. So it is very important to understand that there is no use for the screening MRI to save money. The ordering screening MRI in children with stroke is of no use because you don't get DWIs in that. So that is the most important diffusion weighted image modality, and the ADC is really very important. So DWI, as I said, it gives a it tells us about the cytotoxic edema. So these are some of the images, and so we have DWI. This is diffusion weighted. So as early as 3 hours of stroke, you can see a very bright uh, lesion on the, because it is picking up on the protons. So this is the part where diffusion has been restricted, right? So ADC, it becomes um, um, hypo intense, and this is hyper intense. So when we talk about CT scans, we say the term that we use is densities, and when we are talking about the MRIs, it's the intensities, that because these are the electrical signals. So these are hypo intense signals on the ADC. So what does this tell us? This tells us about the cytotoxic edema usually. So sometimes the cytotoxic edema, if there is a cytotoxic, this will turn into the black image. But if that is neurogenic, vasogenic edema, vasogenic edema, this white on DWI will stay as white on ADC. So this is how we differentiate between the neurogenic and cytotoxic at times. So this is a very important differentiation that we do. The flare image, we usually use flare image for the white matter injuries. These are not specifically for the strokes, right? And then MRA, obviously we see. So if we see the first image that picks is DWI, diffusion weighted image. and again T2, right? This is T2 flare, and then so if you see this image, you won't see anything. 19 hours, even 19 hours, you won't find anything on T2 or flare, right? But you will find some hyper intense signals on DWI. So as the time increases, the DWI becomes even stronger signals, and so it is very very important to order whenever we are asking for an MRI. It has to be usually we don't need contrast unless we are looking for the meningitis or any inflammatory changes in the brain. So what we are looking at in children with congenital heart disease is basically the stroke, and that stroke is can be detected on DWI. So DWI is very very important. So if you have to get one image, that is DWI. And then we also have SWIs and T2 stars and SWI. So what are these images? These basically pick up the small within the magnetic field. They pick up the small interactions or some disturbance distractions in the magnetic field due to calcium ion, due to blood flow. So it basically picks and it gives a dropout signal. So if SWI, if there is something, there is a dropout signal on SWI, it means microbleeds or accumulation of, it may tell you about the calcification, it may tell you about the iron overload. So these SWI images also need to be included in the MRI protocols. It's not just DWI, SWI as well, because most of the centers they don't give this SWI. They sometimes what they do is they see it, they might not report it, and they don't give you the film or the sequence on the CD that they make. So you need to demand from them that we need DWI SWI sequence. It has to be there within the within the CD or the films that they give. See, so these are the small dropout signals that we see. You won't pick them on T2, and this 3T means 3 Tesla MRI, the strength of the magnet. The usual magnet that we use in MRIs is 1.5 Teslas, but that is good enough. So, but see these dropout signals. This is the significance of the SWI. And talking about MRAs and MRVs, these are obviously they give us about a lot of information about the circle of Willis and cerebral venous sinus venous thrombosis as well. So this is important. Radiological phenotypes of ischemic. So we know the pathophysiological mechanisms. We know a bit of the MRI sequences, DWI, SWI. So we know a bit of all those sequences. Now we need to correlate what are the patterns. How do we recognize those patterns? So large vessel occlusion is very very simple. We get the territorial infarcts, middle cerebral artery, anterior cerebral artery, posterior. So we know the territories, and then we figure out which territory is involved. So these are the large vessel occlusions, and then we also see multifocal microembolic showers as well. So if we see this, this is very very interesting MRI. Now this is occlusion. If you see this side is the right side is occluded. MCA, middle cerebral artery, is occluded from here, and it gives the whole area of the middle cerebral MCA infarct, right? So this is DWI. So DWI shows very clearly that this is MCA, left MCA infarct. But if you see the last one, this is very very focused kind of a lesion. It shows that the branch, very small branch of the middle cerebral artery is involved, because it is giving a very small area, circumscribed area. It is not scattered through the whole territory. So this tells us if it's very very small, like on DWI, if you see this and if you see this, so this is the whole MCA infarct, and this is the branch of an MCA. Branch atheromatous diseases, which is common in TOF, and thrombotic occlusions are rare in TOF. And if we see artery to artery embolism, different branches, so we get scattered kind of, which we call micro thrombus and showers, right? And this is the area which is showing the hemodynamic uh, impairment. So this area is basically called watershed. I'll come to this. This is watershed, yes. So what are watershed areas? Watershed areas in the brain are the anastomosis point between the two major arteries. So it's the MCA. So if you see these, this is MCA with anterior cerebral artery. So MCA coming from here and ACA coming from here. So the border of these two, it is the area where there is very low perfusion, generally low perfusion. So if there are hemodynamic instabilities and low perfusion, so this area gets affected. And if this watershed area is, if we see watershed infarcts, this means this is because of the so we pick the pattern that this is hypoperfusion. We need to improve on our hemodynamics. So these are the two basic areas. This one and these four areas. These are the watershed areas. And if we see this, this is due to hemodynamic impairment, and this is a watershed infarct. It is different from the MCA infarct. So recognizing the patterns can give an idea about the pathophysiological mechanism behind the lesion. So these are again the watershed. These are the posterior ones. Again, needs to be differentiated from the press. And so what happens in press is basically it is more of the edema. So the ADC to DWI, the turning of ADC high signals into low signals in the ADC, that is not there. So that differentiates between the press and the infarct. So the press is one of the mimics. The other mimics can be Milas and in some mitochondrial disorders. So this is very typical. These are the watershed areas, but these need to be through different sequences. They need to be, and see this one is again the watershed infarcts, watershed area. So this tells that there is some hemodynamic instability. Then we also um, have this hemorrhagic, very common. Within 2 to 3 hours of a stroke, there might be in that stroke region, there might be a hemorrhage as well. So hemorrhagic transformations are also very important to be picked because of the coagulation risk. So most of the children on anticoagulants, if we find these. So what is the best sequence that we can get out of the hemorrhagic transformation? What is the best sequence that we can pick the bleed in the, yes, SWI is the best to pick on the bleeds, right? And DWI is best picks the diffusion restriction, the stroke. So infective endocarditis and mycotic aneurysms, they are also very typical. They have MRI findings, and so they have basically peripheral. They have these aneurysms are on the peripheral branches of the MCA usually, and they are very typically small. So fusiform, right? So this one that you can see, and on MRI this one. These are the mycotic aneurysms that we identify. So what are the advancements that still we need to, मैं अभी वो पढ़ रहा था कि नीचे आई केम सो आई वो एक बड़ा जबरदस्त लगाया हुआ है कि सोच क्या कर सकती है आपकी सोच है, अच्छी सोच क्या कर सकती है आपकी सोच है. पहले तो मैं उसको ना अपने थोड़ा सा उसको वो किया अपना कि यार ये क्या मतलब है इसका, लेकिन जब उसका थोड़ा सा टोन ऊपर नीचे की ना तो पता चला कि अच्छी सोच क्या कर सकती है आपकी सोच है. So that is a beautiful वो on the ground floor पे मुझे भी वो मिला. So, so advancements we don't have it right now, but we should know okay, what things can be done and how we can make things better. So the most important thing is picking up on those white matter uh, injuries. Sometimes they are very subtle. They don't they are not picked on the conventional MRIs, but if they are picked, it is the what is the most important sequence of MRI that picks the white matter injury? That is flare. DWI for stroke, SWI for bleed, and white matter injuries for flare images. Right. So that is the most important sequence. So sometimes we do pick, and sometimes. So what are the timings of these white matter injuries? They can be, as we said, they can be fetal or pre-operative. They can be peri-operative, and 44% they found that the peri-operative there can be white matter injuries, and which can be actually silent clinically. These white matter injuries, they are clinically silent at times. You may not find any neurological examination findings. The child may look absolutely normal, but you may pick very important findings on the MRIs. So so if you see this, this is the on T1, this is hyper intense, and this is called punctate white matter lesions. These small lesions. So turning hypointense on T2 means this is old lesion. So if it's a newer lesion, it will be white on T2, but as it becomes old lesion, so and then if you see these larger white matter lesions, they may be clinically absolutely silent. And this is the T2 infarcts, right? Arterial infarcts, right? This white turning black, cytotoxic, and then hemorrhages. You see this dropout signal on SWI. So you don't see any difference on SWIs in infarcts, but you do see on hemorrhages. And then subdural and extradural, we can also pick these findings. So what are the newer modalities? Diffusion tensor imaging. So the boring gray images turning colorful. So this tells about the white matter organization in depth. So these images are very important. This is DTI images, and it tells a lot about the white matter injuries, and they are being used. They are being used. So ASL perfusion imaging. So what they do is they label the blood, and then um they send it to the brain arteries, and then they figure out the perfusions within the brain. So this is simple DWI. This gives you a bit about the infarct, but this tells you about the perfusion within the brain, right? So see this perfusion. So we can adjust our hemodynamics based on what kind of perfusion, cerebral perfusion or flow we are getting on the MRIs. So it is imperative the role of neuro radiology in the management. It impacts the acute interventions, and it gives you prevention and hemodynamics. It gives you a lot about the and the cardiac decisions. It gives you a lot of information about the cardiac decision. So how do we standardize? Coming to the point that if you send me a child, what do we do? What things do we see in the imaging in the child? So what is the basis that we give you the answer about the prognosis of that child? So that standardization is very important, not just for the clinical practice, but for also for the research as well. So seeing if we do this standardization in different cardiac lesions and see the outcome, it can be a wonderful research project. So how we do it? So there are 11 domains that we see, and that's a neuroradiological MRI, and we see basically 11 different domains, and then we score it, and the maximum score that we have is 100, right? So we see if there is any focal infarct or not. We know it's large vessel occlusion, focal infarct can be a branch occlusion. So any focal infarct on DWI or T2, we need to score accordingly. And then watershed infarcts, we know what watershed areas are, that is also included. Periventricular leukomalicias and white matter injuries, plus minus cystic periventricular leukomalacia. So white matter injury, again, we do scoring according. Deep gray matter injury. What is deep gray matter? Basically, it's just the island of the small island of nuclei, and there's the thalami, the hypothalamus, basal ganglia. So, and then SWI image. We know, we are well aware of the SWI image, and if we have findings in the SWI images, then we score accordingly. Intraventricular hemorrhages and subdural, subarachnoid, intraparenchymal, choroid plexus hemorrhage, and then we also look at the brain atrophy as well. So this is how we score it, and then we say that the mild injury is 1 to 11, moderate injury is 12 to 32, and severe injury is 33 to 100. So so it is not the basically the management of stroke that matters, but the risk stratification, the scoring, and figuring out which lesion, heart lesion, is how it carries how much risk with the stroke, and what is the neurological outcome. That is really very important. Unless we achieve this, we will not be able to have a proper um, guidelines or protocols for the management of the. That will all be individualized. Individualized mean center based, or it may be the patient based. So we need to work on this and have a proper risk stratification for the strokes. So that's it. Thank you.